Hello, I'm Mark Rickenbach. I'm a general practitioner near Southampton in England and a professor of healthcare at Winchester University. And I'm also the lead for continuity of care at the Royal College of GPs. We're going to start with hearing from the Netherlands, and I'm going to let Otto introduce himself and tell you a bit more about the picture of continuity of care and research in the Netherlands. Over to you, Otto.
Thank you, Mark. So, hello. So my name is Otto Maarsingh, and I will tell you something about continuity of care in the Netherlands. I will first of all tell you something about myself, and then about general practice in the Netherlands in general, and then I continue with continuity of care and mortality in the Netherlands, and current research on continuity of care in the Netherlands, and I finish with a take-home message, and there's always room for questions. To start with, I'm a GP since 2003 and a researcher since 2004. In the beginning in Amsterdam. In the beginning, my area of expertise was dizziness in older patients, but it slightly also covered continuity of care. And until today, I always combine research and daily clinical practice, which is still very nice, I think. General practice in the Netherlands, in short, we have 5,000 general practices in the Netherlands, about 13,000 GPs in the Netherlands. The male-female ratio is about 4:6. Our GPs, GP trainees have a vocational training of 3 years. We have extensive guidelines adjusted to primary care setting, and as a lot of you will know, we have the gatekeeper system. So that means every medical complaint starts with a GP. A study I want to tell you more about. It's about continuity of care and mortality in the Netherlands. It was published in the British Journal of General Practice in 2016, and the main aim was, is continuity of care in general practice associated with better survival in older people? And for this question, we used the data of the longitudinal aging study of Amsterdam, LASA. This is an ongoing cohort study in older people since 1992, and it consists of a representative cohort of older people in the Netherlands, and the data we collect are longitudinal data which are collected every 3 years. For this particular study, we used this LASA cohort for a 17 years of follow-up from 1992 to 2009, in which we included participants with at least 3 subsequent data collection cycles. That means at least 7 years of follow-up. And they also should have a complete data on GP registration. And that meant we had a sample of 1,712 adults of age 60 years and older. And of all these people, we had face-to-face interviews during home visits every 3 years. We had data on the mortality until 2013. We defined continuity of care of the duration as the duration of the ongoing relationship between patients and GP. And we, from calculating the continuity of care, we used the Herfindahl-Hirschman index. I'll tell you more about that later. And we divided continuity of care in 4 categories: low, moderate, high, maximum continuity of care. And for the association between continuity of care and survival time, we used Cox regression. What is the HHI? It looks, the formula looks quite complicated, but this example will give you some background information. When you have a participant with during cycle 1 and 2 who says he has GPA, and for cycle 3, 4, and 5, and 6, GPB, and during cycle 3 has GPC, you can calculate it by adding the squares of the fractions. So for GPA, it's 2 divided by 6 square. For B, it's 3.5 divided by 6 square. And for C, it's 0.5 divided by 6 square, which is a total of 0.458. And given that the continuity of care goes from a minimum of above 0 to a maximum of 1, this is intermediate continuity of care, I would say. So, but this is how you can calculate continuity of care with the HHI CUC measure. So, some of the results, 742 of the participants of the total population had a maximum continuity of care, and of 759 participants surviving the total 17 years in this study, 33% still had the same GP. The population had a mean continuity of care of 0.74. And we found that low COC had significantly greater mortality than the group with maximum COC, with a hazard ratio of 1.2. And there were no confounders that affected this hazard ratio. So to put it in words, participants in the lowest COC category showed a 20% increased likelihood of mortality compared to those in the maximum continuity of care category. As always, studies have strengths and limitations. Strengths of this study is the long follow-up, the representative sample, the use of HHI, continuity measure that allows fraction and is less one-dimensional, for example, than the UPC, and the broad data coverage. Limitations are, we did not use any other COC measure. We did not have data on consultation level, and we have no data on reason for GP change. So on a meta level, you could say, yeah, there is, interesting study. It's a small brick of evidence. However, and Pereira, Gray, and Baker showed us that nowadays the wall of empirical evidence with respect to continuity and mortality, the beneficial effect of continuity of care on mortality, that wall is getting bigger and bigger. And it's also for other outcome measures like hospitalization, emergency rate, quality of prescribing, satisfaction with GP and patient. There is more and more scientific evidence for the beneficial effects of continuity of care. Nowadays, our research group has performed several studies on continuity of care in the Netherlands. We have the TOOL study, an RCT that aims to construct and evaluate a multi-component intervention to improve continuity of care in general practice, and the context study, a large database study. Here you can see a bit more specific what the tool study is. We used surveys amongst patients and doctors to feed, in a way, patients and doctors and practice nurses and and doctors as well, to come to ideas, suggestions, interventions perhaps to improve continuity of care. And by that, extensive harvesting, you would call it like that perhaps, we harvested 297 possible interventions to improve continuity of care. And of course, there were a lot of doubles, a lot of suggestions were not really interventions, etc., etc. So after pre-selection, we had still an amount of 68 or 86 interventions to improve continuity of care. Then we performed a Delphi procedure in which we focused on feasibility and estimated efficacy. And we ended up with a toolkit of 34 interventions to improve continuity of care in general practice. And that toolkit we're testing right now in a stepwise design randomized controlled clinical trial. So another study is the context study. And for this study, we have a large database that consists of 270,000 patients, 50 practices with 6 years of follow-up, and more than 5 million journal topics. And we are calculating continuity of care for each individual patient and then making averages over the years and looking for the association between continuity of care and patient and GP characteristics, and also the association between continuity of care and prescribing quality, but all still work in progress. Finally, I have a take-home message. Discussing all the benefits of continuity of care, I would say, as GPs, we daily prescribe drugs that are proven ineffective. I would say, like, for example, anti-vertigo medication for dizziness. I would say it is time to start prescribing personal continuity. Any questions?
Thank you, Otto. That was really good. It's fascinating to see, and it's lovely to feel the wall building, and not only just building in one country, but building across several different countries. So it's really good to hear about that. And of course, in the Netherlands, the structure of general practice and the gatekeeper role is quite similar. So it's fascinating to see how much comes out from your country that contributes to general practice in so many ways. I was interested to hear about those studies, and you mentioned a thing called data at the consultation level, and I'm just wondering what you're meaning by that, because that was quite interesting what the consultation level was. It was one of the things that you were picking up.
Oh, yeah.
You hadn't quite done. Yeah. So,
yeah, thanks for the question, Mark. That's the first study we did, that British Journal study. We only had data on GP registration. So I'm a participant, and I tell every 3 years to you, as being an interviewer, my doctor is Dr. A. Yeah. And after 3 years, I tell you again, my doctor is Dr. A. But that is limited information. It tells, and when you ask me that for 20 years and I still have Dr. A, okay, I have Dr. A for a long time, but perhaps in the practice, I see also Dr. B and Dr. C, and I do not visit that much Dr. A. Yeah. So it's only my idea of who I'm registered with.
Yes. Yeah.
And it can differ.
Yeah.
But it's interesting, and that's actually why I used the metaphor or the symbol of a large wall. That studies have also been done. But this is a study that's only about GP registration. Who's your GP? But other studies give us information about the association on a consultation level, and they provide this. They deliver at the end the same proven association between the beneficial effects on mortality.
Yeah, so you've contributed several bricks to the wall, and other studies have added to it. And of course, the general direction is consistently in favour of continuity helping.
Yeah.
So it's the weight of evidence comes from that, which is really good.
Yeah.
And of course, in England, we have this issue about which person they're seeing, whether they're seeing the GP or the nurse or the triage person or the paramedic or physio. So that complicates it a little bit more in our consultations. So we're looking at that as well. So that's where we have to think about the types of consultation. That's really good. So what I'm going to do now is open it up to the audience and see what questions they generate. So thank you very much indeed. And I look forward to discussing things a little bit further shortly.